Instead of trying to adapt the patient to our technique, we should adapt the technique to the patient's anatomy.
What are the most common risks and complications that you see if you stick to this very rigid one-size-fits-all, for example?
Complications related with soft tissues, which means soft tissue recession, soft tissue infection. And the second one is related with sinus. So sinusitis, rhinosinusitis on possible oral-anterior communication. What we like to teach is not how to treat those complications, but how we may prevent those complications.
Welcome to Straumann ProTalk Clinical, where vision, skill, and science converge to disseminate knowledge and shape the future of implant dentistry. Today, we're diving into the evolution of zygomatic implants and how each time more individual characteristics matter so much more than the rigid one-size-fits-all approach. Today, I'm joined by a true pioneer whose name is a synonymous of zygomatic implants and true passion for education. Professor Carlos Aparicio, thanks for coming to Straumann ProTalk Clinical.
Thank you, Chris. Thank you, Chris. It's really an honor to be here. Thank you.
I will start by setting the foundation. We often hear that zygomatic implants is often the last resort. How is the role of zygomatic implants and therapy in the full arch context in today's modern implantology?
Thank you for the question, because I think it's a very relevant one. The placement of zygomatic implants must follow a true indication. The indication is atrophic maxilla. This atrophic maxilla, the origin of this atrophy could be the loosening of a tooth because of infections, and also could be the failure of previous treatments, like implant treatment or grafting procedures. So previous considering the placement of a zygomatic implants, we must consider the placement of a regular implant. Of course, now it is very common to tilt implants in order to find some bone where it is. So this is why we say that you may place a regular implant, please try first a regular implant. In such a way, we are keeping this tool as a last resort. That's the meaning of the last resort.
And how does the ZAGA philosophy help differ from traditional implant placement in the zygomatic indication?
Allow me to tell you a short story.
Please do.
I learned zygomatic implants. Well, as you know, the idea of zygomatic implants comes from Professor Pierre Groneman, but he didn't like too much to teach himself. In order to really to teach how to, he delegated into Chantal Malevet, a nice and good, perfect surgeon, maxillofacial surgeon, that on top of this, she does prosthodontics too. At the very beginning, we learned a recipe that was an universal recipe for, as you said, one
size fits all.
One size fits all. That's a perfect definition. So we tried to masterize this recipe. So we were following, during the first years, following perfectly what we learned. Try not to get apart from these teachings. But we observed that we got some complications from the original recipe. And I guess that about 85% of the first surgeons receiving this knowledge gave up. Why? Because of the original complications.
They're frustrated.
Totally frustrated. Though we were surgeons placing on the selection of the first surgeons, we were surgeons placing more than 2,000 regular implants a year. So I think we can call us expert surgeons. What happened is that after a while, I realized a very simple thing. And that simple thing is that you and me, we are different. And we are different for him or for her also. So there are differences between human beings. And still there are even more differences between atrophic maxilla. Because those atrophic maxilla, the origin of this atrophy, as I said before, is very variable. Can come from just for the tooth loosening, but usually they come from previous treatment failures, like implant failures or grafting procedures. So at the end, there is no regular anatomy. So finally, I understood that instead of trying to adapt the technique, vice versa, instead of trying to adapt the patient to our technique, we should adapt the technique to the patient's anatomy. And that was the fundamental of ZAGA. And after this, we understood that it is not only the technique of the implant placement. It's about adapting the incision, adapting the flap, adapting the whole procedure to the patient's anatomy. Even the implant itself should be adapted. No, if for regular implantology, we have like hundreds of implant designs. At that time, we just had one design for a very much complex anatomy. Can you imagine we have to go through an alveolar bone that many times there is no alveolar bone, just few remains of alveolar bone. Then we have to go to proceed to the maxillary wall. How many shapes has or may have the maxillary wall? Even is concave, convex, thin, thick. And then finally we should anchor on the zygomatic bone. So we have to go through many different anatomies and have only one implant design. That was not logical. Exactly. Not logical. So this is the origin of ZAGA, trying to adapt the whole procedure to the patient anatomy.
I like this very much because all of us who are passionate about implant dentistry and have followed zygomatic therapies for a while, we have seen the evolution extramaxillary, through the sinus, outside the sinus, in many configurations, and always being with the sense of too risky. But now we see how you have adapted and evolved, putting the patient in the center always, not putting the technique in the center, and the patient is just something that is sitting there. And for doctors that are still hesitant to be very patient-centric, to adapt to the techniques, what are the most common risks and complications that you see if you stick to this very rigid one-size-fits-all, for example?
Of course, we divide complications into intrasurgical complications or maybe early complications and late complications. I don't think it is necessary to talk too much about intersurgical complications like orbit invasion, or because I guess that every surgeon has skills enough to escape from those complications. But the hidden complication to me is the one that is going to appear to show up in the future, not tomorrow, not in 1 month, but in 6 months, in 1 year. And those complications mainly are two. There is a complication related with soft tissues, which means soft tissue recession, soft tissue infection. And the second one is related with sinus. So sinusitis, rhinosinusitis on possible oroantal communication. Those are the two late complications that we are afraid. So what we like to teach is not how to treat those complications, but how we may prevent those complications. Because in this patient, there's always what I call the risk balance, Whenever you like to escape from the soft tissue complication, you are inclining the balance for the rhinosinusitis and vice versa. Whenever you try to escape from rhinosinusitis, you are knocking the door for the soft tissue complication infection. So it's about knowing which resources you have to deal with this so much atrophic maxilla for this patient that has no bone on the maxilla. And with this implant placement that is forced to be sometimes in an aerial path, and how we are going to prevent the complication of soft tissue recession or infection of the sinus. So this is the trick.
And you cover now the potential complications surgically wise. And we have this patient that has been restored. What are the most common technical complications that come restorative-wise over the period of time? In terms of anterior-posterior spread, how do you consider this and how this affects the prosthesis afterwards?
Well, social media make the trends of the life, and also in dentistry they make trends. I can say that we were, the very beginning of zygomatic implants, we were taught to place a few regular implants on the front, either on the pristine bone or using a grafting procedure too, plus 2 posterior zygo implants. This was the original teaching of P.I. Brodemar. After a few years, we started with the quad procedure, which means that it's a quadruple placement of zygomatic implants. 2 zygomatic implants on the right, 2 zygomatic implants on the left. The ideal spread of those implants, anterior-posterior spread, is about placing the anterior implant on the position of the lateral incisor and the posterior on the position, average, on the posterior on the position of the second premolar, first molar, distal second premolar, mesial first molar. This is a position we would like to have it a little bit more posterior, but usually mouth opening, lower dentition, long instruments are going to limit this position. But the good thing is that if you are able to place an implant on the position of the lateral incisor and a second implant on the position of the second premolar, first molar, the AP distribution is enough to have a regular dentition, at least molar, first molar to first molar, so 12 teeth without any problem. And this is not going to give you any problems on the prosthesis. I started answering your question about the tendency of social media because placement of 2 zygomatic implants is not easy. It requires some skills. So now it's like the tendency of either placing those 2 implants in a very parallel position, which is easier, but then you are creating a long cantilever anterior or mesial and a cantilever posterior. So then you need some implants, regular implants there and pterygoid implants on the posterior. So either this procedure or placing just 1 zygo implant, and then you have to go for a pterygoid implant or an implant on the nose, which is not, has no proven long-term results. So those are the tendencies today.
There's a bit of a give and take into both possibilities. So you don't see many prosthetic complications, fractures or anything like that. Similar to any other full arch therapy.
Exactly.
Technically speaking, restoration should be safe.
Exactly. So at the end, if you are able to get a good implant stability, for sure, and a good AP anterior-posterior spread, then the final result is going to be very, very similar, especially if you follow the ZAGA philosophy of trying. So you must know what is your goal when performing an osteotomy for implant placement. And the goal in this case is first to achieve maximum primary stability of an prosthetically driven implant. So we want our implant platform to be either on the crest or very, very close to the center of the crest. So the prosthesis, the final prosthesis is going to be very, very similar to a regular rehabilitation.
And just to wrap this, because we often see, especially because of the length of the implant, right? There's a pre-assumption there will be some movement potentially. Will this affect the restorative scheme? How does that work?
That's a very interesting question. Well, the first answer, we published together with Professor Thomas Albertson a paper that is called ORIS criteria, in order to establish which criteria we should use to determine the success or failure of a zygomatic implant. One of those ORIS criteria is the ORIS is the acronym of offset, rhinosinusitis, infection, rhinosinusal status, and stability. So stability, one zygomatic implant, as you say, you can find a little movement sometimes, not always, but sometimes. And this little movement may arise from either the destruction of the total destruction of the alveolar bone. So meaning that the implant, I call it occipital part. This part of the implant is not supported either by alveolar bone or palatal bone. So the implant has only the anchorage on the zygoma, and so the implant is like this, anchored there in my zygoma, and then because there is no support here, you can bend it. So you are creating a very long arm. So now you can get some little movement. So the principle for the zygoma is, please don't destroy the alveolar bone. Be conservative. This is what we call ZAGA minimally invasive osteotomy. So you have to place the implant platform, the implant posterior part of the platform supported either by alveolar bone or by palatal bone in the case. But say that we are totally against of those philosophies that say your first action should be destroy the alveolar bone.
I see.
And then get anchorage up there.
Wherever you can anchor.
This is, if the problem of this patient is maxillary atrophy, why should I increase the problem of the patient by destroying, unnecessarily destroying more bone? And this applies also to this window osteotomy that I was taught to perform this window osteotomy. But we must understand that when Professor Bronnemann had the brilliant idea of this treatment, at that time, he had no softwares, diagnostic softwares. They have no CBCT, they have CT, but with a very, very humble software managing the CT. They have no 3D models. So the tools they had for diagnosis, they were very limited. So he said, okay, let's stay on the safe side. Let's make a hole first in order to see my dream. But today, this is an emotional osteotomy. Yep. Emotional. We don't need to destroy bone. And the same thing with the slot technique. They make a slot previous to the, so a slot osteotomy previous to the osteotomy necessary to place the implant. So why 2 osteotomies for 1 implant placement? There is no sense. Imagine we are placing a regular implant. What is our goal? Our goal is to under-prepare in order to achieve maximum primary stability. So what is the meaning of destroying bone, especially in a patient suffering from maxillary atrophy? There is no meaning.
Yeah.
No meaning.
Thanks for clarifying. So in your point of view, now giving a recap, primarily we should aim, of course, for the anchorage, but to have the coronal part of the implant well supported. This will potentially minimize any arm force, stabilizing the prosthesis, minimizing technical complications over the time.
Exactly.
Did I get that right?
That's the full idea. We have a new paper that hopefully will appear in soon. Let's call soon. It's in the process of reviewing, but it's accepted, where we are demonstrating how it's a finite element analysis study, and we are working with two models. One representing what we call the ZAGA 3 situation, which is about the 20% of the cases. And the second model represents a ZAGA 4 situation, so maximum atrophy, which represents about 60% of the population. So this is about, altogether, they represent 80% of the atrophic maxillas, posterior atrophic maxilla. And then we are applying three techniques to each model. The oversized osteotomy, the osteotomy that is not achieving support on this posterior part, so only anchorage up there. The original surgical technique following the PI Brannemark protocol, and the ZAGA protocol adapting the osteotomy to the patient anatomy. So we've been able to see that when following, of course, with the extramaxillary technique, it's not necessary to add too much because it's a very dangerous. It's very common that this big level arm ends up with an implant fatigue fracture. But when following the original surgical technique and at the same time dealing with the most atrophic maxillas, the end result is that the part of the alveolar bone that is supporting or counteracting this long level arm is very thin because the atrophy is big. So it's about 1 or 2 millimeters of bone supporting the masticatory load.
Yeah.
What happened? Today, nothing. Tomorrow, nothing. But in 1 year, 2 years, this small amount of bone has a concentration of masticatory load. And at the end, it will be resolved. And after this, what is going to happen? After this, it comes the oral-antral communication, the infection of the sinus, which was about 26% of the cases of PI Brannemark, as he reported. Yeah. This is the percentage of the original PI Brannemark paper.
That's a perfect segue to our next topic, because we have a section called "It's Not What We Think, It's What We Know." Yes. Evidence matters, correct? And I asked you to highlight one article that it was impactful for you in your career, that either opened your eyes or helped you pave and shape your career towards this direction. And you shared with me the article "Reconstruction of the Premaxilla with Autogenous Iliac Bone in Combination with the Osseointegrated Implants," in collaboration with Dr. Olivier Keller, but also the one and only Professor Brannemark. It must be quite an experience. I would like you to share what was it like to work with Professor Brannemark, and how and why this paper is so meaningful to you.
Well, this is a paper reflecting our first collaboration with Professor P.I. Brannemark, and it's the story of a young man, 18 years old man, that suffered a surgery, an orthodontic surgery. So the orthodontic surgery failed. And this was 87 around, so the late 80s. We started with regular implants on 84 and opened an office exclusively devoted to regular implants in 85, which we were like crazy guys at that time. Crazy guys. So no dentist in Spain knew about modern implant dentistry. We were waiting for referrals patient. Was like a crazy thing. But well, I don't know how this young man came in. So the result of this orthodontic surgery was he lost the whole premaxilla from premolar to premolar. He got like 15 millimeters communication nose-mouth.
Wow.
So it was like a disaster.
All out of an orthodontic surgery.
All because of failed orthodontic surgery. So it looks like the surgeon made a maxillectomy, and then he tried to lower the maxilla, and then he lost the vascularity, and then he got a necrosis.
How sad.
So Ignacio came to us, and then we were like, so it was, and then we called P.I. Ranimer, and he said, okay, come here, come to Gothenburg. We said, he seems to be very, very sure. But we were able to arrange the paperwork for Ignacio, and Social Security paid for Ignacio to go there. P.I. Ranimer didn't charge anything. And himself, he made 2 implants, long implants, with a machine he used to have in the office. He turned the 2 implants. And Ignacio was also double lucky because at that time, Eugene Keller, that at that time was he was the dean of the maxillofacial department at the Mayo Clinic. Eugene Keller was spending a sabbatic year in order to learn regular implants. I'm going to repeat it because, so the big boss of the maxillofacial department of the Mayo Clinic, Minnesota, is spending 1 sabbatic year in order to place a regular implant, not a Zygomatic implant. No, a regular implant.
It's the opposite.
It's like the opposite as today. So, but the thing is that Eugene Keller was able to close the communication, nose and mouth. P.I. Ranimer got a hip graft, and he secured the graft with those 2 implants, 2 long implants. So after this, and then we performed the rehabilitation, finally in Barcelona, to this man. And the lessons I learned, that today maybe you are going to smile, but the first lesson I learned is that no matter if you place an implant in a non-perpendicular direction to the occlusal plane, no matter if you place an implant in a tilt direction, it may work. That was the first thing, because we were amazing. So the implants are not like this, are like this. Oh, and they are working. Incredible, because at that time, there were instruments in order to place implants totally parallel, perpendicular to the occlusal plane like this. That was out of the box. And the second thing is that there was the possibility to remotely anchor an implant and still working there. So those were the 2 lessons I learned from this patient that really changed my career, totally changed my career.
And this is what sparked this fire to remote anchorage.
Exactly.
Dedication throughout your career.
I would say that first we started inclining implants. That was the first step, because everything is not like a miracle, a light like this. It's an evolution. So first we started inclining implants and developing like a 3D inside of my head, a 3D vision inside. So I'm inclining this implant like this, and I will get anchorage behind the canine, for instance. I'm going to escape from a sinus grafting. So that was the starting. And we prepare, we like, without knowing, we were preparing for the Zygo implants. And finally, the Zygo implants in a regular manner came in 98. in 90. But during this time, we published on tilted implants. So it's as a preparation, as an evolution. Yeah.
And to everybody who's interested in this paper, we're going to leave the link to PubMed where this paper is published, available to everybody just to click and go through and see this amazing paper from 1993 from Professor Carlos Aparicio and Professor Brannemark, of course, with collaborators. We have another section, as you said, the experience and things that you faced, that is called Experience Taught Me This, right? Of course, we cannot be too critical on ourselves because the knowledge base we had a few years back is not the same as we had there. So in our heads, those were the right decisions for the right moment. But in retrospect, knowing what you know now, is there any case that pops to your head that you say, oh, time is the best educator. I wish I knew back then what I knew now, and I would have come differently to that patient?
I think I cannot tell you one specific case, apart of the one we have just commented, that he really changed my perception. Because it's been, again, an evolution. So then you try to follow the original recipe. You follow. I don't want to change anything. I want to masterize what I learned. But you get a problem. And then the good point is that, and I'm very proud of that, in my office, I had a rule. The rule was, whenever you have a problem, take a picture. Take a picture now. Don't fix it. Take a picture. And then you have the opportunity to think about the problem. So the idea behind this is about, this is a new technique. Well, not anymore, but at that time there was a new technique. Nobody is teaching me. So we should learn about our experience. And we should separate topic by topic. We cannot put all together and try to get, no. We have this problem, so let's analyze why, what is the theology, and then you take one thing, and then maybe you can vary just one thing, and wait and see the results. Wait, and you see the result, but just one time as one thing at a time. Not you vary like 2 or 3 things. You cannot deduct from where the problem or from where the solution arises.
Yeah, sometimes we cannot remember every single patient, but we can tell how your head was thinking at certain periods, right? And with the evolution, now you see things completely different.
Yeah, the thing is that at the beginning, you get a problem and then you don't know why. And then you think, oh, shit. Problem. And then the normal human being is, then so you try to look to the other side, you go. Yeah. But I like to go back.
Right.
To go back and to think, that's, and this is when you bring the problem to the weekend. Yeah. And then your head is thinking, and at the end, maybe you get the solution or not. In our office, we have a protocol. And the protocol, one of the protocols we have is that one person was collecting all the emergencies happening and what was the treatment and what was the origin. And then we were reviewing all the month emergencies. One day was reviewing emergencies. So what was the emergency? What happened? What was the treatment? Who did it? And which department? And then there was like a discussion about the emergency. Can we do something for the next thing? Cannot. So it's the way you have to learn. You have to put some order in order to learn. Otherwise, it's like maybe you are inspired, you learn, or maybe you are not inspired and you don't.
And I like very much your rule in the office to take picture.
Yeah.
If you don't document, it becomes only a fisherman's story, right? It's something that maybe happened, nobody can prove. So I like this learning mindset. I would like to shift gears a little bit more If we look future orientation, we have quite an evolution in zygomatic treatment therapies. Now, looking future-oriented, how do you see the biggest shift will be? It could be either in implant itself or how digital technologies, for example, helping us get from point A to point B, or artificial intelligence maybe helping you predict some pitfalls. How do you see this rapid digitalization and looking into the future of zygomatic therapies?
Well, it's not easy to answer the question.
Because we don't know.
Yeah, that's the first thing. And the second reason is difficult is because the huge variability of anatomies you may find. And usually those differences are arising from previous failures, as we just comment. Previous implant failures, previous grafting failures, procedures. So this means that it is quite common to find, for instance, bone discontinuities that makes any guided solution like I will be very grateful if we are able to develop more diagnosis tools, diagnostic tools. So I'm so happy using a software to planify. I'm so happy using 3D models to planify, to make a rehearsal surgery. We have today, maybe we have commented, we have amazing 3D models that we are fabricating in-house in ZAGA headquarters, because this is a very powerful tool.
Right.
Maybe AI can help us in diagnosis. Could be. I'm not very confident in guided systems. Why? Because this big variability of anatomical situations. To me, guided surgery is, especially for talking about zygomatic implants, is maybe can be adequate for, never are easy, but for, allow me to say, more simple zygomatic implant placement, where you have some kind of bone or some little amount of bone. Yeah, maybe for this you can use it as guided, but when it comes the situation, the very frequent situation where you almost don't have bone, or where you have this like paper sheet bone that you try to cut it and you find this sound, this horrible sound, because it's not possible to cut this paper sheet, then I cannot see the utility of those guided systems. So, in resume, I will be very grateful if we develop more diagnostic tools, more softwares, things that make the surgeon more comfortable at the moment of the real surgery. Yeah.
I like, because your expectations are quite realistic. It's almost pretty much a present, huh?
Oh, yes. Thank you.
Professor Aparicio, it was an honor to learn from you today.
Thank you.
Thank you very much for stopping by and participating at Straumann ProTalk Clinical with us. And to all of you interested to learn more about zygomatic therapies, the ZAGA concept, and throughout the whole ZAGA, I would do that
philosophy.
Again. No, it was the ZAGA centers. And to all of you interested to learn more about zygomatic therapies, the ZAGA concept, and all the ZAGA centers, also learning with Professor Aparicio, make sure you click on the link that will appear in the video description and you have access to this amazing network. Professor Aparicio, it was a pleasure to have you with us.
It was also my pleasure, and I really thank you for the opportunity to share a little bit more about the ZAGA philosophy, which I think is a very powerful tool, especially for these people that are desperate, that are facing the last opportunity to recover a fixed dentition. This is really the last opportunity. There is only one shot. We have to be successful in this unique shot. So thank you. Thank you.
Thank you very much.
Thank you.
And to all of you, remember, if this content was valuable to you, make sure you like and you comment and you share to your friends. Sharing is caring. Until the next episode,